If you agree, we're gonna send the video and let Professor Khanduja make the introduction, and then so we can continue and you can invite the speakers afterwards for the session.
Please, you can start the presentation. We have a technical problem, so if you hear me, please you start your presentation.
Okay, right.
Go
Can
ahead.
you hear me? Can you hear us? Perfect. Right. Good afternoon, everybody. I'm Vikas Khanduja. I'm a consultant orthopedic surgeon in Cambridge, UK, and also the current president of SICOT. And it's an absolute pleasure to be actually hosting this event in the Somali Congress. We've focused mainly at this event to the low-income countries and the topics related thereof. And we've got fantastic speakers who agreed to give up their time for this session. I would also like to thank Sayid, who's worked extremely hard to get this SICOT session into the main Congress. And this is being broadcasted not only on our website, but also on LinkedIn all around the world. So very momentous occasion for all of us, focusing on low-income countries, specific topics related thereto, and broadcasted around the world as well. And I'll stop with that and I'll share a couple of videos with you about SICOT and where SICOT is going in the future. Please have a look. So as you can see, SICOT is global. It is the oldest orthopedic organization in the world. In terms of offerings, it is offering you a significant amount in education, in research, in advocacy. So be a part of SICOT, and the membership fee is the lowest is there for any global society, especially for the low-income countries. And I'd also like to welcome all of you to Madrid, which is our annual Congress happening in September. And Sofiene will bring up the video to tell you about the Congress for that as well in a second. Hey, evening, ladies and gents. This is Vikas Khanduja, president of SICOT. I'm here in Madrid at the Riyadh Football Stadium promoting the SICOT Congress. We've got an excellent scientific program prepared for you with over 450 speakers from all around the world, 20 keynote speakers and plenary speakers as well to entertain you academically. And on the social front, Oliver Marine Penna, my partner in crime, has organized a fantastic social session at the casino and also at the Bernabeu Stadium, where we'll have our networking event. So all in all, get yourself prepared for an academically and scientifically fantastic meeting, along with social networking with almost 3,500 orthopedic surgeons from around the world. Nos vemos en Madrid. So we welcome all of you to Madrid. And once again, thanks to Sayid, thanks to all our fantastic speakers, and have a great session. Thank you very much.
Thank you, Dr. Vikas. So please, all of you can start your presentation.
Hi, Dr. Mahmoud, I believe you can start because Dr. Kallel is not there yet.
You start, yes. You can start, please. Professor Sofiene, Professor of Orthopedic Surgery based in Tunisia. Please, can you start your presentation? If you can hear me, please, we need to start the presentation. So, Prof. Dr. Sofiene, please, can you start? Dr. Sofiene.
You can start the webinar, there's no presentation.
Dr. Sofiene.
Dr. Sayid, we're supposed to introduce now.
Dr. Sofiene.
He's not there. He's not there.
Dr. Sofiene.
He's not there.
Yeah.
We'll see the next one.
Yes,
I think you need to begin with the people available now.
We are the available people. We can start us.
Is Yasin available?
Yes, we can hear you. So please start your presentation.
You can start
Yasin?
with Dr. Yasin. Dr. Sofiene Kallel is not there. You can start with Dr. Yasin, please.
Yeah.
Yes, Dr. Sofiene, please, you can start.
Dr. Sofiene is not here.
Okay. Dr. Gamal Hosny, you can start your presentation.
Okay, I will.
Okay, bro, welcome.
Okay, thank you. First of all, I would like to thank the Somali Orthopedic Association for the invitation. You know, I have many fellows from Somal and many patients too. We consider Somalese people are our brothers. I'm going to talk about recent advances of pediatric orthopedics in our environment. We have many things in common. When we talk about pediatric orthopedics, we talk about severe congenital deformities. What about pediatric orthopedics in Africa? We have high incidence, high growth rate, maybe more than 3%. 1/3 of the population is under the age 15. Late presentation and consanguineous marriages. When the people wants to make a scheme or a protocol, they always look for English literature. Unfortunately, talking about especially the congenital deformities, the English literature, most of the ideas are hypothetical ideas. Why hypothetical ideas? Because the incidence of congenital deformities in the States and Europe is very low. So tibial hemilia is 1 per million live birth. So if we, in a country like England, if you have the birth rate is 600,000 per year. So every 2 years, you will find one patient with tibial hemilia. So it does mean that low surgical volume, higher volume improve the patient's outcomes. And this is the issue. In our area in Africa, we have many patients with congenital deformities. So we have to learn from each other, from our experience with this large number of patients. Again, the people, they talk about the treatment protocol. If you think about the treatment protocols in the States or in Europe, they teach you that if you have a severe congenital deformity, like congenital absence, fibula, and you have less than 3 feet, 3 ray foot, you have to do an amputation because this is non-functional foot. Do you think this is reality? Look to this patient with 1 toe. She's walking almost normally. So I called it animation-based classifications. It's not real classifications based upon hypothetical ideas. Even she can run with normal sports shoes. Look, this patient with fibula amelia, 1 deformed finger. You see the way she runs. So we have to have resource-driven adaptation. Adaptation is very important for survival. So what are you going to do? You have many patients with congenital deformities, many patients with pediatric orthopedic issues. And if you want to apply the principles you have learned from the English literature, you're going to face confusion. Confusion between fiction and reality. So I'm going to show you some classifications which are just published recently. Proximal femoral focal deficiency. My classifications comes after 30 years of experience with 927 cases. Number 1, morphological abnormalities. 2, congenital abscess, total abscess, partial abscess, abnormal proximal femur, apparent nexoarthrosis, coxavara, and short femur. And this is published in the Pediatric Orthopedics. It comes from the high number of patients we are dealing with. And this is type 1. The whole femur is there, but it's not in the normal position. It's transverse femur. Congenital abscess. This is complete absence of the femur, but this is the tibia. You see, with the follow-up, with the longer follow-up, the medial tibial plateau changes the shape into medial femoral condyle. Partial absence of the proximal femur. 3, apparent nexoarthrosis. Coxavara. 4, just short femur. Also tibial amelia, the new classification. My new classification are based on 566 patients. Type 1, complete tibia, small one. You see, this patient presented to me at the age 26. Type 2, absence of the distal part. Type 3, presence only of the proximal part or enlarged. Type 2, diastasis. Type 4, adasis. Type 5, diastasis of all these. The bones. Type 6, complete abscess, which is most common. And this is the example how we manage with such cases. This is complete abscess, presenting late, presenting to us at the age 5. Usually when you face you find the protocols dealing with the patients at birth, but usually we have neglected cases in our areas. And this is the way we treat it. We don't do fibular shortening at all. And we do centralization another way. You see the way we do it? In one stage. It's called 3-in-1. Why 3-in-1? 3-in-1 because the patient cannot go back and forth to have different 3 treatment phases. Another type, reversed ankle technique. With this type, we do reversed ankle. You see, reversed ankle technique. This is the fibula, which is high, and this is the tibia, which is low. Because we rotated the ankle, because you have instability. We don't have to simulate the normal ankle because we don't have the normal components. Standing the test of time. Because we do follow up the patient for such a long time. See, this patient with TR syndrome, thrombocytopenia absent radius syndrome, presenting late. Again, this is the way the patient walks. We used 8 plates. This is not 8 plates. This is regular plates. And we cut it into 2 holes plates because it's far cheaper. So you can use regular plates to do guided growth. And with guided growth, you have this picture. Full correction. Again, derotational osteotomy was done. And this is the patient after graduation from the university. Again, he's a Paralympic player. You see the way he exercises. 19 years follow-up. Chronic infection. Chronic infection is a terrible thing in our area. And this is an example. Spina bifida, chronic osteomyelitis, and many previous operations. Usually, the treatment is amputation in the spina bifida, insensate foot. And this is after multiple debridements. What we do is a different thing. We do transverse bone transport and corticotomy first technique. We do, this is transverse bone transport, multiple drill holes, 2 centimeters by 15 centimeters, like this one, and we leave it in place. Then we put Hafez and we pull this piece of bone 1 millimeter per day. This increases the blood supply of the whole limb. You see the transverse bone transport. And this is after 1 month, 2 months, 3 months, and this is just before removal. This is transverse bone transport, which is indirect measurement to treat chronic infection, severe infection. Again, this is after New Year's. The patient presented with the other side. We did transverse bone transport, and it worked out again. After 7 years, so after about 9 years from the originals, he came with chronic osteomyelitis of the right foot. Again, we did longitudinal bone transport, corticotomy first technique, and we corrected the deformity. And you see, this is after debridement, after 1 month, 2 months. And you see the picture now. 1, 2, 3 in the same patients. Transverse bone transport, and longitudinal bone transport. I have many Somali people, fellows from Somal, and I would like to invite all of you to participate in our annual deformity conference, 23 to 25 July this year, after a couple of weeks. Please come. We have many international speakers, and we have 12 workshops. We are going to show you how to use the low income resources to treat the most difficult cases. In conclusion, there is no one-size-fits-all solution. The treatment strategy can be modified according to the available resources to treat large number of patients with congenital deformities. Our management approach or protocol, new classifications based upon fair number of patients, follow-up, long follow-up, and late diagnosis, single-stage surgery, 1-day hospitalization, new reproducible methods of limb reconstruction to avoid amputation. Thank you.
Thank you, Prof. Gamal Hosny.
You're welcome.
So still we have technical problem in our side. So please, if you can do another presentation from your side.
Please, Dr. Hafez, you can go ahead.
Hafez, okay, that's me.
Welcome,
Thank you.
Thank
Dr.
you.
Mahmoud, Hafez.
Hafez, thank you. Just share my screen.
Yes, please. Very clear. We can see you.
Okay.
And we can hear you.
Thank you so much for inviting me. I wished to come to you in Somalia and present this face to face. And hopefully this could be done later on. As Gamal said, we have many similarities. We are in the same continent. We are in Africa. We have more or less the same issues with regards to patient demands. And safety requirements is a standard in the whole world, but because of the constraint that we have, that's why I'm giving this presentation to see how we manage this problem. Okay, this is my disclosure, and this is the objectives of my talk. So basically, we have patient needs, especially for arthroplasty. We have patients who wants to do a knee replacement and want us to pray and squat and sit on the floor, or maybe using like a floor toilet and things like this. And on the other hand, we have to do the operation using the standard, standard requirements for knee replacement, which is global. But how can we do this in presence of the constraint? This is what we're going to do. We have also to look at the cost versus the value of healthcare and in general, and then TKR, okay? And how we're going to manage this cost, how the cost is calculated worldwide, and how are the different methods of calculation and how this fits to our practice. And I'm going to tell you about my experience. Although I practice also in UK, but I'm going to only focus on my practice in Egypt. And also, how can we use technology? Technology normally is extremely difficult. How can we use like robotics navigation, which is extremely expensive? And how can we use other technology like PSI to reduce cost? Normally, technology involves more, but how to use technology to reduce cost? That's what we're going to see. If we look at this picture here, this is what I see in Egypt, and what I see also from patients come to me in Egypt from many countries in Africa and Middle East. I don't see this in UK. No way I can see this in UK, very rarely. Okay, because patients usually present late. So when you have bilaterality and you have severe varus and flexion deformity and severe arthritis, as you can see in the X-ray with bone loss, that may require putting a stem. And with this high incidence of knee osteoarthritis, and on the other hand, a patient has high demands. They just wanted to sit and squat and pray with their knee replacement. And also they have different economy and psychology. They are worried. They are afraid from having surgery. And with all these limited resources, it's very difficult to do like bilateral. And even if you do unilateral here, patients are not satisfied because you straighten one leg and the other leg is short and deformed, and the patient is not happy. They say that, oh, you lengthen my leg, and they are not equal, and they cannot walk properly until they do the second one. But they can get complications because they have imbalance, and the knee replacement can get flexion deformity afterwards. So basically, what is a knee replacement? Knee replacement is a surface replacement where we are making minimal cuts on the bone. It's not like a hip replacement where the head and neck are thrown away, but here it is on the surface, but we have to shape the femur, specifically the femur, because we have to create 5 surfaces in order to fit the implant on them. And for the tibia, it's probably easier because it's just only one cut. But how can we make all these cuts, especially if you're doing a PS knee and you have to make a box cut? So in order to make all these cuts, it is a machining and an engineering work that requires accuracy and reproducibility, and at the same time requires a lot of time during surgery, many steps, more than about 70 steps, in addition to a lot of instrumentation system. And this is the mainstay of my talk here, an instrumentation system. You see this instrument, which has been there for about 50 years, since 1970s, and has not really been improved until they introduced robot and navigation to replace this instrument. But these costs are huge. with like a robot with $1 million. There's no way for African countries to buy a robot unless it's a private company, sorry, a private hospital, just, seeking, patients through marketing. But if you look at this instrumentation system and you look at the safety requirement for joint replacement, where in order to do a knee replacement, in UK, I'm not allowed to do knee replacement unless the operating room has got laminar flow. So with orthopedic theaters, like in any hospital in UK, you see some hospitals, they have laminar flow ventilation system and some others don't. So for joint replacement, it has to be done in a laminar flow. And this instrument has to be under the laminar flow. So this is not achievable in Africa. It's really difficult. Expensive system, laminar flow is not available in the majority of hospitals. So this means that the risk of infection is high. Adding to this, there is also a risk of fat embolus, because if you see a patient that I presented earlier who requires tibial stems, in order to put tibial stems here, there is a high risk of fat embolus. So you're using conventional methods. You're reaming the medullary canal in the femur in order to put the rod and the guide. And then you're using tibial stems bilateral. Then the risk of fat embolus, you are actually killing your patients if you're using conventional instrumentation. So how can we do this? It is a catch-22. Here, there is a huge difficulty. We need to do bilateral, but we cannot do it because we don't have robotics and navigation. So maybe we could have PSI. Let us see. So when we look at the value of healthcare, how this value is calculated, we need really to get less complications. We really need to get satisfied patients. We need to get technical success. And in order to achieve this with the safety in presence of our constraint, then the knee replacement has to be cost effective. Knee replacement has been proven to be cost effective worldwide, but we need to find out, can it be cost effective in our countries? That knee replacement can reach up to $70,000 in certain hospitals in US, okay? And if you're using robotics or navigation, it could be even higher. But with all these major costs, it's cost effective. So how can we do knee replacement in Africa? And the cost could be less than like $3,000. And how can we make this cost effective? Again, it is a mission impossible. Catch-22, as I said. Let us see how can we do this. This is the analysis of the cost in different countries, and this is variable because you see many different private hospitals and government hospitals also, they have different costs and different cost calculation. I don't want to bother you about this theoretical ways of measuring the cost calculation. They are like a traditional method. There is like a time-driven activity-based costing, and there is patients and family-centered care methodology. So there's different ways that in US, they are trying hard to reduce the cost and make the knee replacement more cost effective and make it more value for money. Here is like a publication in GBGS about, the cost analysis and all these sorts of things for knee replacement and again for hip replacement. I mean, you can look at this, and also I can send you my presentation later on to be available as PDF or a PowerPoint, okay? So this is again for hip replacement. So when we look at how can we reduce these costs for total joints? We need to do a lot of things. Well, some of them including also rehabilitation, and also we need to compare with other joints, and we need to think about using technology. Let us see this in pictures, maybe make it easier. Here is also some examples of Africa and Asia and the cost and the demands for knee replacement. There's huge demands. I made just a simple calculation to show that in Egypt, we have at least 1 million patients who need knee replacement, because many of the patients who come to me, they say that they have been advised to have knee replacement 10 years ago. So there is an accumulation of cases. Okay, so how can we tackle this problem? What do I do in Egypt in order to get this balance? I actually use this technology of patient-specific instrument where I do CT scan. CT scan is very cheap, okay? It is not like in UK where a CT scan could be reaching from 250 to 500 sterling pounds. In my country here, it could be costing like 20 or 30 sterling pounds. So it's very cheap. We do the CT scan, we have a special software, we do the whole planning on a software, and then we know the sizes, we choose the best implant, okay? And then we can make the whole simulation of surgery, including cuts and balancing, everything is done. And after that, that software is clever to create a guide, and this guide is specific for the patient. It only fits on that knee, so you cannot do the right side for left side. So it has the name of the patient on it and the side and the size of the implant, and this is done with using technology of 3D printing. It is so simple, and it can be done like in 1 or 2 days maximum. And doing this, we have these guides, we can sterilize them, and then we go in the operating room, just doing the approach and the closure. Adding to this is about like less than 15 minutes for doing the whole bone cuts. If you're doing uncemented implant, then definitely that's not going to take time at all. But in Africa, the majority do cemented TKR. So with that, you can really reduce the time of the operation significantly and not going through medullary canal, and reducing the risk of fat embolism, reducing the risk of bleeding, and also infection, because there is no instruments like this. You get rid of this instrument, you get rid of the intramedullary guides, and this is the reduced set of an instrument. And I continue later on how this can reduce the cost. There is another thing which we have in Africa. We don't have a stock of implants in hospitals. It's not like in Europe or States where every hospital have their own implants stock and instrument. Here, everything comes case per case. So you can imagine that a stock of implants coming in a bag like this, and this bag moves between different hospitals. This is another source of contamination and infection. And you see, we waste time sizing the implants and looking for sizes, and we always have problem of the stock. We may have some sizes missing. We don't get this with a PSI. PSI, we do the planning, we know the sizes. If this size is not available in one company, we get it from another company. We go to the operating room with tibia and femur and probably a set of polyethylene, just to make sure that we get the right, size for the polyethylene. The PSI doesn't accurately measure polyethylene, unfortunately, but polyethylene is just a surgeon's feeling. And I think that's not a problem, having different sizes, like 5 different sizes of poly. I normally, with the using of the PSI, minimal cut is done for a tibia. So normally we use between size 10 as an average, but between 8 and 12 as a maximum and a minimum. Okay, so the cost of TKR, for example, we have a model here where I had this done for a charity. In the past, I did it for about 1,000 but the cost of the implant now is more. So we do it with 1,500. And I can set this model in Somalia, and I can help you doing a knee replacement with that minimal cost. You might be surprised and say, all right, how can you do this? Is if the cost of the implant could be like a $2,000. Yes, we can get the cost of the implant less if we buy a lot of implants with no instruments, no stock of implants. They don't send the stock to you. They just don't send the sizes for that surgery, and they don't send a medical rep, which is like a routine in our countries. So in this case, you can reduce the cost of the implants significantly. And if this is a government case or a charity where surgeons don't take fees, then the cost could be really as minimal as that. Like if you're doing even for private and you want to give high costs and all that sort of things, with that PSI, you can reduce the cost like a maximum $4,000, while in average in US is about 40,000. So it's 10 times less. This is an analysis of the cost. I don't want to bother you with this busy slides, but you can see the differences between conventional and PSI and the difference in the cost. The only extra cost for PSI is just the cost of the CT scan and the cost of printing the guides, which again is very minimal. It is something like, could be less than 50,000, sorry, 50 US dollar. And it can be even get less and less if you're having like a hospital-based system, which is something that we did. So if we look at the analysis of the cost here was pre-operative and post-operative, and then the hidden cost, like the cost of instrumentation system, which is equal to about 100,000 US dollar. That cost offset towards the cost of the implant. So if you're not using them, then definitely the cost of the implant will get less. So that's the, like summary of the cost comparison, and you can see how much saving that you can do. So as a cost analysis, the PSI reduced the cost for about 23%. And that's major saving, because you're saving an OR time, shorter hospital stay, fewer complications, less bleeding, less blood transfusion. I do the 5% of my cases with blood transfusion for unilateral and about 16% for bilateral, and less sterilization and instrument handling and less cost of implant for the companies. So that PST, or sort of PS or PSI, patient-specific template or patient-specific instrument, it's also great for cases which you cannot do with conventional technique. When you have extra-articular deformities, you cannot put the intramedullary guide. When you have retained metal that you cannot remove in a femur tibia, you cannot put intramedullary guide. When you have bilateral simultaneous with severe articular deformities like the one I showed earlier, when you have bleeding tendency like hemophilia, we can do bilateral hemophilia cases using that PSI, or medically unfit patients, okay? So this is just one example of a complex case that we see cases like this in Egypt, a chondroplasia where you cannot get the intramedullary guide or extramedullary guide, no way that you can do any planning or make any accurate cutting for a case like this without using technology. We have so many cases, complex, not necessarily achondroplasia, many other conditions. I don't want to, overload you with many slides. This is just my last slide with a conclusion. So I want to say that we can use technology here in Africa to reduce the cost and to make knee replacement more cost effective with less number of operative steps. As with the PSI, we can reduce number of steps from about 70 to about 60 during the surgery, reduce the number of instruments, reduce operative time, reduce complications, and reduce cost. Thank you so much for listening, and I would love to come to your country and present this further. Thank you. Bye-bye.
Thank you, Prof. Mahmoud, Hafez. So the presentation was very good and must hear it. So we will try to present it on our side. So now I will call Yasin Barkhad. Can you hear us?
Yes, please go ahead. Dr. Alaa, I think you can proceed.
If you have a problem, guys, I can present the bone and soft tissue defects.
Excuse me, Gamal.
Alaa is there. Yes.
Yeah, I can present if you want. Is that okay, guys?
Guys, Alaa is there. He can present his presentation to resolve the problem.
Because they asked me. I think they asked me.
Yeah. Yeah, go ahead, Alaa.
Yeah, please go ahead.
Go ahead.
Okay. So I'll share my presentation. Is it clear?
Yes, it is clear.
Yeah.
All right. Thank you very much for having me. I'm really honored to be participating in your Congress in Somalia. Looking forward to have more collaboration. In case people who don't know me, my name is Alaa Azmi Ahmad. I'm a pediatric orthopedic surgeon, but mainly focusing on spine deformity in children, and I'm Palestinian, and I'm based in Ramallah, but I'm having a lot of global activities that I would like to share with you about my experience in managing deformity, infection in low resource settings. So if you think that the problem, especially in scoliosis, in spine, if you think the problem is financial, you're wrong. Of course, we mean about the financial, the prices of the implants and the materials donated and the surgical equipment. Actually, the main problem is the organizational problem. Always in most of our countries, we have weak organizational activities. What we mean that effective training, equipped nursing, clear guidelines and protocol regarding medical error, clear protocols about communication with different healthcare institutes, incentives for data collection and research, and many more. So I wanted to say that in the beginning because I wanted to show you how can we have a successful spine program within the constraints that we have. So if we talk about the hospital facilities, infrastructure and equipment limitations, lack of specialized facilities, many hospitals have lack of dedicated spine surgery units. In most of the countries that I went to, there was no spine surgery unit. And besides, there are many countries, especially in Africa, who don't have, for example, an MRI. They have a CT, but they don't have an MRI. So the patient must go to another hospital to do that on his expenses. And inadequate surgical tools. I mean, inadequate surgical tools, like even you don't have sometimes appropriate rongeurs, appropriate osteotomes, and appropriate curates. And this makes a huge difference, especially in spine. In spine, it's a very neat surgery. 1 millimeter here or there makes a huge problem for you. So unfortunately, we face these all the time. And what about the workforce? Of course, in general, there is a significant shortage in neurosurgeons and orthopedic surgeons, not to mention spine surgeons, not to mention pediatric spine surgeons. And also surgeon, unfortunately, because of the circumstances, lack of continuing education. You know, you are in Somalia and you know, problems for the visa, financial problems for, even if you go to a country in the West to learn, it most will be observership and you'll not touch anything. And this is bad if you want to begin your practice in your country. Implant expenses. Then we go to implant expenses. Spine surgery is expensive. If you want to do just one case of scoliosis, you'll put at least 15 screws. Usually we put in adolescent idiopathic 20 or more screws, and this is expensive. And unfortunately, even, you know, I go to countries in Africa, even if you have an insurance, a health insurance, a governmental health insurance, you must pay for the implants. I don't know how it is in Somalia, but in most of the countries, it's like that. And this will decrease the dissemination of this service in these countries. Data. And this is a huge problem for me. Unfortunately, until now, in most of our low middle income countries, still we think that research and collecting data is a fantasy. And most of us are concentrating on how to do the surgery, how to put the screws, how to do the derotation, the technical details. But if you want to evaluate what you are doing, you must have the data. It's not like I'm good or bad. It's the data that will make you feel that you are progressing or you are having one year of experience that is multiplied by 20. So this is important. And the post-operative care, of course, post-surgical rehabilitation is often overlooked. For continuity of care, especially if the patient is far away from the capital, which is usually the place, or the big cities are the places for these activities in the spine. And also the intraoperative neuromonitoring, it's a huge add to the safety in spine surgeries as a whole, and especially in spine deformity in children. To be clear, if I can compare 10 years ago when I was going, most of the countries didn't have an intraoperative neuromonitoring. Now, most of them are having intraoperative. So it's a big change, even in the low middle income countries, the importance, the acknowledging of importance of the intraoperative. So we can talk about that in every field, like Dr. Jamal Hosny, like Dr. Mahmoud, but what about pediatric spine? What are the problems in surgery was relegated as a low priority status in global health. Many short-term missions were used as an excuse not to implement permanent pediatric spine management. Misconception of the high per unit cost of pedicle screws making surgery unfeasible, inability also for local surgeons to learn and implement the treatment. So unfortunately, it was like just mission coming for a week from the West, having all the tools and doing the surgery and going back. Nobody will learn anything. And this was, until recently, this was the thing for specifically the pediatric spine. What have changed? Increase awareness of the importance of the problem. When you know that 4% of your young children are having scoliosis, 25% of them, so nearly 1% of them need surgery, that's huge. Epidemiological shift with the global industrialization gave importance to surgery as an important health factor, and this is through the WHO. Global activity has changed. There is a huge shift from short-term missions to capacity building and focusing on education more. And you can see it with the SICOT also. The change in perception of highly specialized surgery have changed. So it's not, the highly specialized is not like something that you can put behind, or it's not no, it's a priority, like dealing with malaria, like dealing with TB. Awareness of the effect of globalization. You can realize after the COVID that even the developed countries are aware that if the health situation in the developing countries is bad, it will affect them sooner or later. So there is more curious action on these things. Because I talked about organizational defect, if you want to have sustainable program, you need to have a champion, a local, otherwise it will not work. Why is that? Because when you work in a skeptic environment, and we don't have lobbying issues like in the West. You need to convince the government. The government is all of all. And you need to go to the key guys to persuade them to get the program done. And this needs huge effort. I mean, really huge effort from champions who bear on their shoulders how to implement this difficult issue and how to convince the key people to do that. Otherwise, it will not work. And I have seen many champions in many countries, and it's not us who implemented the program. It's us, but they were the main core for that. And hopefully, and I'm sure you have champions, which I know one I mean personally. And due date, it cannot happen that the collaboration between the global surgeon or the global organization with the local surgeons, it cannot be, I mean, a teacher-student relationship forever. So it should have an awareness that this global organization collaborate with these local people to have within, for example, 2 to 3 years, that we'll have a local team that can do the adolescent idiopathic, straightforward adolescent idiopathic cases. And then you can have a plan for 2 to 3 years to perfect the early onset or something like that. But it cannot go as a vicious circle beginning from zero every time. Sustainability. Once the training program is underway, it's not just doing surgery. It's always the feedback, which is very important. And you must, as a local surgeon, know that you are the important person. It's not the global surgeon. You are and you must give the feedback that should be acknowledged by the collaboration between the global and the local organization through a feedback that should be acknowledged from the local surgeon. So we have just some tricks about the management within the restraints that you are having in your non-surgical techniques like casting. Casting is very important, especially in early onset scoliosis as a delay procedure. You can see these people, they were in Kenya actually, and they were having early onset and there were no facilities to do the surgery. You can do the casting, it will delay the surgery, will stop the progression of the curve until you have it, and you must master it. And as you can see on the right side, you don't need the specific table, the riser table. You can just have 2 couches and do it very well. Also bracing. Bracing is very important. Unfortunately, we as surgeons, we look for surgery, but bracing might avoid surgery for many people. And this is what we do, what we should do. We should do the minimum with the maximum effect. And it's mainly used for adolescent idiopathic cases. And who are indicated in these cases? Patients with curve between 25 to 40 degrees and rapidly growing, smaller than 25 degrees, but show more than 15 degrees of growth. Patients who have riser 2 or 3, that means that they are going to puberty, but the curve is 40, between 30 to 40, and with thoracic and double major curves. And here is a case of my cases in Palestine. You can see this case after 3 years of putting the brace. You can see her, she's very well compensated. And the thoracic curve is 19, the lumbar curve is 22. She was actually 30 degrees when she came to me. So if I didn't put the brace, she would have been 40, 45, 50, and she would have gone to surgery. So it's cost effective, and it's very important also to avoid surgeries. What about the surgical tricks? You need to develop a cost-effective surgical techniques within your hands. What you can do, you cannot change the plan of Ministry of Health. You cannot have, a new hospital, and also you cannot wait until you have the excellent, for example, beds for surgical beds for your, like Jackson table or something. So you need to think about cost-effective surgical techniques, and I'll show you examples. Here, for example, when you distract soft tissue, away to expose the spine, you don't have a cell saver. Sometimes you don't have tranexamic acid, and I see that in many places. So you need to do a technique that will decrease the blood loss. And this will happen if you train to have a new technique. When I go to any country to begin scoliosis, I begin with this technique, not putting the screws. And I teach them how to do it in the most appropriate, efficient way to decrease the blood loss. Beside that, especially if you are a beginner, if you work in a pool of blood, you wouldn't see appropriately. And if you put the screw, you'll be so stressed and you wouldn't know how to put the screw because it's very dangerous. If you go just 2 millimeters medially, you'll have a catastrophic issue. So you need to have a plan field. So just a surgical technique within your hands. All what you need is just a cob, and you can have a bovie, and you can do it very well. Another thing, in our low middle income countries, you can see these horrible neglected cases of scoliosis. If even in the best hands in the world, even if you have the best surgeon in the world coming to you, he or she will really be irritated to do these surgeries, and they'll have complications which are huge. One of them is paralysis. So what we have done in Tanzania, for example, we did a workshop. Actually, there was something called halopelvic traction. It was introduced and innovated in Gurki Hospital in Pakistan by Dr. Saad Ilyas, whom you can see here with the glasses and with the jeans, and in Gurki Hospital with his team. And it was very effective, very cheap, and affordable, and can be done. And also, it has a huge privilege that you can avoid in the halo gravity. The people, when you go outside the hospital, they are irritated how to deal with it. But with the halopelvic, you can avoid that. So what we did, we had a 2 days workshop in Moi Hospital in Tanzania. And we had these sessions that you can see on your left side. And we had 6 surgeries done by halopelvic traction. And after 2 months, we came back and we did the final surgery. This is how we did the halopelvic, and you can realize the difference. And we did a paper. This is how you do it. When you do something, take the data and write a paper about what you have done. And these were the cases. And you can see here, most of these cases, except one, we had more than 90 degrees, the Cobb angle, which is huge. And you can see post-surgical correction at the final follow-up, and it was around 50 degrees. You cannot do it by just an index surgery. So the halopelvic was a great option, and I think you need to think about it seriously. And we can manage through the SICOT to have a workshop about the halopelvic and do it in Somalia, and you can begin with it, and it's easy to be done. Also, affordable techniques. For example, in early onset scoliosis, you don't need to have the magic rod of $20,000. You can do it with just regular distraction every 6 months, though it's very hard, but you can have the traditional, what we call the traditional growing rods, as you can see here. Also, there is the APC technique that I invented, and it's done in many countries all over the world. And you don't need except regular screws, regular rods, and regular dominoes, and also you avoid the recurrent distraction. And the paper about it was, as you have seen, won the best paper in the Global Spine Journal in 2024. What about the infection? We have the infection problem. And here is a study by the North American Spine Society Journal. It was done about the infection in the spine in the MENA region. That means Middle East and North Africa. And you can realize who were the risky patients in the statistically significant diabetes mellitus, revision surgery, cases like having a problem in the heart, problem in the lung. So if you want to deal with infection in low middle income countries, the best thing is prevention, not to deal with the infection, because dealing with infection is a big problem financially, and you cannot afford to have appropriate 6 weeks patient is in the hospital with heavy doses of antibiotics. So preventing infection is your priority. So always check the patient seriously. Don't look at him or her as a spine. Look at him or her as a general health issue that you need to evaluate. For example, undernourished, you need to just give them appropriate nourishment. You need to check the albumin, albumin globulin, immunity system. All of these things are important to avoid infection. Other thing to avoid infection, some things that you can do within your own capacity. Here is a study, current strategies in preventing post-operative infection in spine surgery. And you can realize just you test through a nasal swab if the patient is Staph aureus carrier, and you just give them intranasal mupirocin ointment and 5 days of shower wash with chlorhexidine. It will decrease the infection to 40% for the Staph aureus. This is a study. So you can do that to prevent infection. Also, another thing, putting vancomycin as a powder in the wound. Here you can realize, even in America, it's cost-saving option. Just put 1 gram in patients below 30 kgs, 2 grams in patients above 30 kgs, or, if they are 50, 60 kg body weight, you put the powder in the wound and you'll decrease the infection hugely. So you can realize, even in America, it was cost-saving about $450,000 in 100 spine fusion performed. So you need to think about how to prevent the infection. And these examples are things that is within your capacity and within your hand. And also about learning. We had done an experience that we have done with SICOT. We did a blended learning course for South America. 300 people, 300 surgeons came to this course, and it was very successful, talking about early onset scoliosis and adolescent idiopathic scoliosis and spondylolisthesis. And also we did a blended learning course for Africa, for the COSEXA. It was based with Tanzania and with the Moi Hospital. I think you need to think about it very seriously. It is cost effective. You can learn a lot, and you can do it in your free time, and it really gives good knowledge. Also, there is the proctorship that I have done in Nicaragua, and we did it then in Kenya. And you can see the hand, the yellow hand or the green hand is my hand. And I was on just my laptop, and the people in Nicaragua were doing the surgery, and I was guiding them. And you can see also my hand is on the C-arm, and I was in Palestine, in Ramallah, and they were in Nicaragua. And look at that. This was the first case that they have done in scoliosis by their team, local team alone, through guiding them through this proctorship program. It's cost effective, it's very efficient, and you can do it. And they have called me to guide them in the second surgery, and they didn't even call me for the third surgery. So this is what we need, that the local people will have continuous education. You don't just depend on the mission, you depend on and in between the missions, you can have this proctorship program and the guidance to make your surgery safe and to feel that you are supported by a global surgeon. And what we did, again, we didn't stop. We did a defining metrics for assessing surgeon performance during telementoring program, this program. And it was published in the Global Spine Journal. And it was the first that we did a metric evaluation of the competencies of the surgeon who's doing adolescent idiopathic scoliosis. And it's a huge advancement. And we are looking forward to have more advancement in this technique that will help mainly people in low middle income countries in scoliosis training. This is what we have done in Kenya, and we relied on it to do the study. So, framework for monitoring and evaluation surgical system have been proposed to better integrate spine care into national health strategy. This include tracking surgical volume, workforce density, preoperative mortality. These interventions show that the right mix of innovation, collaboration, local empowerment, spine surgeon in low middle income countries can be both safe and effective. So it's not just surgery, innovation, collaboration, local empowerment, and this depends on you guys. And this is a book that I was a co-author about how to implement early onset scoliosis in low middle income countries. It was published in 2020, and we have great experiences from many places in low middle income countries about that. And we are looking forward to see many of you in Madrid in the SICOT. Thank you very much. Oh, stop sharing. Okay. So,
who's going to talk next?
Hello,
Hello?
can you hear me?
Yes, yes,
Yes.
we can hear you.
Yes.
Yes, we can hear you. تفضل.
Okay. I am Dr. Yasin, and I am honored to present Somali's prospect and information about the arthroplasty in our country. During my session and presentation, I will be talking about some background of the arthroplasty in Somalia, the current status, the challenges we are facing, and our future aspirations regarding the arthroplasty. First of all, let me give you a little information about our country, Somalia. Can you please mute yourself? Our country's area has 6,337,657 kilometers, and You see that we have got a longest coastline in our country, and the population in our country is expected to be 37.2 million by 2050. The population density is 31 per kilometer square. Hello? Well, this is Somalia, and it's at the edge of the Horn of Africa, in East Africa. The background of arthroplasty in our country is relatively emerging, and it's a recent surgical advancement in the country. The type of arthroplasty that we perform are mainly due to chronic neglected cases and sequences after war-related musculoskeletal injuries. The healthcare infrastructure in our country has experienced prolonged collapse, which is limiting the access to specialized surgical care. And the data that's available, I am going to share with you during this presentation, has only been recorded in the past 10 decades. In the past 1 decade, it's past 10 years, I mean. The present progress, despite the challenges, we have got an emergency of local orthopedic surgeons. Several hospitals are recently offering arthroplasty, and there are also innovative companies that are importing implants to our country. If I continue, current status of the situation of arthroplasty in Somalia, mainly we perform primary hip and knee arthroplasty, which is the main constituent of replacement procedures worldwide. As all similar to other cases, we make preoperative planning when we are planning to perform a surgery, including history-taking, physical examinations, investigations, and imaging. Although that these are mainly limited, and sometimes the resources of the patients, we may not perform full investigations and imaging in Somalia. However, we try to, as much as we can, to follow the guidelines. After the imaging of X-ray, we don't have advanced technology. However, we do use our computers and our desktops to plan the surgery. And some of our patients are really, we normally try to draw lines and measure the angles and the length discrepancy on the computer. Mainly, the approach that we use, me and some of my colleagues, are hardening approach, the direct lateral. However, several other surgeons also approach posterior hip when it comes to hip arthroplasty. I'm going to show you some cases that we have performed in Somalia. One of the first one is 32-year-old male who was neglected case. That, as you see, he had a femur neck fracture for a long time, and he did not seek healthcare, maybe due to a limited resource or limited healthcare surface in our country. After a preoperative planning, we have performed a total hip arthroplasty, and it's clearly you can see the patient again started to walk. The next case is 52-year-old male who had a AVN and similar to other cases did not get the care of initially. However, when he came to us, he presented and his image looked like this, and we finally performed a total hip arthroplasty. I'm not going to share every case that we have performed, but I'm giving you an opinion so far our capacity in the country based on hip arthroplasty. This is also another case. We also perform knee arthroplasty in our country, and this is one of our cases. So, despite that we have started and initiated some arthroplasty cases in our country, we have several challenges in our country that I'm going to discuss and eliminate one by one if it's possible. One of the challenges is that we do not have a limit centers in our country, that only few centers are available that can perform arthroplasty. We also face a challenge regarding human resources, implants, and also we don't have
sub-specialists and sophisticated trainees. And we also face a challenge when it comes to cost, that arthroplasty is very expensive and the majority of patients cannot afford to pay it. And also there's a lack of knowledge and awareness about what arthroplasty is and what are the indications among the population, Somali population. Geographically, this is the map of Somalia, and the dots that I have shown as the three main cities in the country that has a centers that perform arthroplasty. The other parts of the country, there are centers that sometimes perform, but it's not a majority of the time. It's a campaigns and only certain surgeons go there and perform, or maybe. And also the challenge is that the implants are not widely available the rest of the country. So these three cities, Mogadishu, Hargeisa, and Garowe, are mainly the centers that perform arthroplasty routinely. The other challenge we face is that we do not have a human resource complete, that our trained technicians, orthopedic theater technicians are really very small number. And we also face a challenge when it comes to postoperative rehabilitation support. Majority of patients, when they come to these arthroplasty centers and you perform arthroplasty, they have to stay in the city for rehabilitation for prolonged period, because rehabilitation support is not widely available from the rural and the areas that they originally come from. One of the main challenges that Somali people face, especially the patients, is the high cost of the procedure, because the patients are the ones who are paying the money from out of their pocket. There is no governmental insurance or public funding that is available which supports this kind of surgeries. Also, there are no hospitals or public hospitals that provide maybe discounted or any other services for the people. All the centers that I have mentioned and all the people that provide arthroplasty are private. So the cost is really a concern for the population. That leads to limited access for low-income population. It leads to delayed or unmet surgical needs in Somalia. The other challenge that we sometimes face is some procedures are very complex, neglected, and other procedures that is not performed in Somalia. I have already mentioned only hip and knee. We don't perform shoulder. Despite some of our surgeons have got the knowledge and skill to perform the shoulder, unfortunately, we have not access to the implants. We don't also perform as well elbow replacements. This is mainly due to the implant availability, and also despite some surgeons' performance not widely sub-specialized area, and our surgeons do not have done. Some of them cannot perform it. Some of the implants that cannot be available are not available include the arthroplasty refusion set. For example, we don't have that acetabulum refusion caps. And if there is one hospital or one center that performs, widely the rest of the country and the rest of the surgeons do not have an access for this kind of implants. Also, knee arthroplasty, we mainly perform primary. We don't have these long stems for the refusion knee arthroplasty. We have done a survey this year. Somali Orthopedic Association has collected data that previously presented earlier today by my colleague Sayid. When it comes to arthroplasty, regarding that survey, 21 doctors participated, and when it comes to this number, the number of surgeons who are member of Somali Orthopedic Society are almost 60, and around 40% or 40% are only work in the country. The rest are come and go. So based on the country's doctors, this is 21 centers that contributed to the survey. It revealed that the most surgeons had 3 to 10 years of experience. And 18 of these surgeons, which are 85% of the number, they perform hemoarthroplasty. And 14 of them, which is 66%, perform total joint replacement. However, only 11, which is around 52%, have arthroplasty status in their hospitals. The other common challenge that we face and also reported by the respondents in this survey are some of them lack of implants or instruments. The surgeons responded that there's a poor infrastructure in their settings. The other challenge that there's reported is that the patients have good false conception or misconception regarding arthroplasty. They also reported that there's an influence from the traditional bone healers who doesn't believe or trust the arthroplast. The other challenge that reported by the respondents is infection and surgical limitations which relate to a skill. So as a Somali Orthopedic Society, we think, based on our capacity as a society, that there is some hope we can perform in the future strategic priorities to improve the care. One of them is to establish standardized arthroplastic training programs for the orthopedic surgeons in Somalia in order to deal with the complex cases that we face. Another thing that we believe which can solve a lot is to foster partnership with the innovative implant companies in order to improve access to high quality implants in our country. That's my conclusion. I would like to summarize and take a home message regarding my presentation. And I have mentioned that arthroplasty is emerging in Somalia, and it's widely, a lot of centers started performing it, but it remains to the only few urban centers. The system faces major challenges based on the expense and the public misconception, and also the lack of a center or a public center for referrals of high complicated cases. We also, there's a, because of the expense and the lack of government insurance, it severely limits the access of the most patients for this care. My message is that strategic partnership, training, and local innovations are essential to scale and sustain arthroplasty services nationwide. Thank you so much.
Thank you, Dr. Sayid. I think we can conclude the session.
I think we can conclude, yeah. I'm very sorry. We had so many connection issues. Can you hear me?
Yes, but we did it.
Yes, yes, we can hear you.
Next time will be better.
Yeah. Thank you so much, guys. We had a great session, and although we had some technical issues, but there were about more than 150 participants. 43 of them were orthopedic surgeons in the room. The others were general surgeons, other physicians involved in trauma care and orthopedics. So we appreciate your input. We had another spine surgeon who is online, but we have very bad connection here in Somalia. So I appreciate your support. I thank you on behalf of Somali Orthopedic Association and its presidents, and I hope next time we can invite you. So thank you so much, guys.
Thank you very much.
This was great.
Thank you.
Thank you.
Yeah,
Thank
you so much, Sayid.
Thank you.
I'm Mahmoud Hafez. My video is disabled, so I can't show myself. So thank you for your presentations and giving us a chance.
Thank you so much. Thank you so much.
Thank you. Bye.
Bye-bye.